Hello everyone and welcome back to the final episode of 4 episodes with Kadia regarding her paper on diseases in conflict zones of Cameroon. Today what we're going to focus on is 3 separate little bits, and one of the things we wanted to discuss was very much about healthcare systems and how healthcare systems cope in disasters, especially conflict disasters, but also in more broader disasters. We also wanted to focus very much on data and the use of data to collect both within disasters and diseases, but also more broadly in the whole field of disasters. And lastly, we wanted to focus very much on lessons learned from this case study and what other countries can learn from Cameroon. We hope you enjoy today's episode.
You mentioned IDRiM systems, used in other conflict settings. First of all, what does IDRiM mean? And what do those systems, what makes those systems better adapted for emergencies?
The E1 system is the early warning, alert, and response network. So it's a parallel surveillance system that the World Health Organization puts in place to support fragile states who are experiencing public health emergencies. So in essence, it doesn't replace the integrated disease surveillance system in place. It just comes in to fill in the gaps in terms of, reporting, in terms of, strategizing, understanding where to act and redirecting resources. So yeah, that's really what the early warning system, the early warning alert and response system is there for, and it also brings in technical expertise to support the fragile health system. And when the system is able to manage, then they extract themselves from the country. There's this transition and they step out and allow the routine integrated disease surveillance to take place. So they usually come in during emergencies. That's really the pertinence of the E1.
Okay, so it's it sounds like a very useful system if you are under cholera outbreak, Ebola outbreak, or plague, to help that system from basically stopping it from collapsing, under the strain of these infectious diseases.
Exactly. It really helps the system to support it, not to, because the integrated disease surveillance and response system is not adapted for emergencies, but most low-income countries still depend on its functions to respond to public health emergencies, which is very, very inadequate because it's there to generate routine data. But the early warning system is there to generate prompt data for a specific emergency.
And also, just to say as well, don't forget that it's not just lower income countries that struggle with, health emergencies. Developed ones we've seen through COVID. No healthcare system, pretty much, could respond to the absolute outbreak of COVID. And one of the reasons in the UK, we had the slogan, stay at home, save the NHS, because one of the things was we knew that if everyone got infected at the same time, the NHS would have just collapsed in the UK. And, I mean, it was one could say it was almost at the breaking point, even during the first, wave. It was struggling to cope, and we had like makeshift wards just for respiratory diseases, and people didn't go to hospital for regular checkups, regular appointments, which put other health, ailments later down the line as an emergency. So it's not just, I would argue against just saying that it's low, helping low income countries who, healthcare struggles.
Yeah.
Really, when you take a more of a step back and look at all healthcare systems, I don't think there's many that can cope with emergencies.
Yeah, definitely. The COVID challenged so many health system, even robust health system. So I mean, every country was in need of such a support. Every country was in need of such a support at the time.
Mm. And actually, moving on, and diseases sometimes feel, in disasters is I hate to be disparaging here, something I think I am, that diseases are an afterthought after a disaster, but actually they're an important, integral part of any disaster response, and actually can be arguably as dangerous, if not more dangerous, than if it's a if like a polycrisis or multi-hazard crisis where you've got an earthquake, then you've got a cholera outbreak because of the infrastructure being damaged. A cholera outbreak is actually you could say is just as lethal than the original earthquake, or what other hazard starts first. But also diseases, obviously like COVID-19 can be the forefront, hazard. And the reason I keep mentioning about this is that your paper connects strongly to the Sendai framework. Um, how should DRR practitioners think differently about health surveillance in the view of trying to reduce mortality and harm towards, disasters in a view through a health lens?
Wow, thank you very much. That's really you really went in depth in the paper. Yes, you know, as you say, diseases cut across every disaster. They cut across every disaster, but it's not always recognized like that. And we should not look at disasters in an isolated way. Increasingly, practitioners are approaching, even the health aspects of things from the One Health lens, which is okay. What role does the mining system has to do in the health, the geography of the health, and all of that? But the disaster risk reduction framework really emphasized the importance of having disaggregated data during emergencies. As you said, the health aspect is very important, and one that is even often overlooked is the mental health of people who survivors of disasters or people who are undergoing protracted conflicts or protracted impact of disasters. There, there, there are no platforms specifically in Cameroon that recognize that, for instance, someone who has gone through a cholera outbreak has survived while they saw other people around them passed pass on because of that cholera, has a certain level of appreciation of life that may not be like before. And so, what's the impact of having of integrating those people in the community. How does it look like? There is no system in place for that. There's no system in place to identify those cases, and it's because of how we collect our data. So the framework emphasized on how we collect our data that reflect a long-term manner of addressing the problem in question. Yeah, so that's really it. Practitioners should focus on addressing disasters in a wholesome way and conducting risk assessments that integrate different aspects of the emergency, not just what's specific to their specialties.
And I mean, the perfect example, of, to illustrate this point about taking a whole, disaster view towards healthcare is Hurricane Katrina in 2005. Now, we know that Hurricane Katrina killed 1,170 people in Louisiana. But what a lot of people don't actually realize with that is actually the biggest cause of death was disease. Now, it's not always disease like cholera or even, those types of diseases. It's about other diseases that, people in the communities actually have as well. I'm looking at this and it says that 47% of hurricane victims died of acute chronic illnesses, in hospitals or nursing homes, many of which would have been prevented if they had the right medication, if they had the right healthcare, if they were in the right place to be looked after. And cardiovascular disease was the biggest killer in Hurricane Katrina, or one of the biggest. And so we're not even talking about now diseases like Ebola, cholera. We're talking about stuff that we can actually, every day we manage in our healthcare system. Heart attacks, strokes, these types of things, people who already have long-term illnesses. When these disasters happen, a lot of time the system fails straight away. And this is America we're talking about, in that case study. You'd think that in America the system would cope. It didn't. And that's, for example, it says here, especially in every age group, in one parish, in the Orleans parish, it said that pretty much everyone over the age of 45 onwards were more likely to die of disease and drowning. In the eldest age category, if you were 85 and above, you were twice as likely to die of disease than you were of drowning. Now, you think of New Orleans after the 2005 Hurricane Katrina, the image everyone always had in their mind was drowning, the water. But what we find is actually in a lot of cases, it wasn't drowning that killed a lot of people. It was actually preventable diseases that were killing people. And this is where there's this big question then, and this is why I asked this question about, the Sendai framework and, thinking differently about health surveillance, is that sometimes I feel that healthcare has been given as an afterthought. That the main response is the disaster themselves. Get people into shelters, get people out of harm's way. And as I said, that I was putting in inverted commas. But what next? You can put them in a shelter, but if that shelter doesn't have your, a Pixaban copy dog roll, it doesn't have them ones that are stopping you from having further heart attacks and strokes, what's the use of being putting in a shelter? Because you're probably putting that person at massively increased risk, or even killing them. So I just think that's why I asked that question, because I feel that it's in most disaster contexts, it's the bit that we don't think about and we don't appreciate as much. Okay, so just moving on, and we still got a little bit left. I really did go into this paper with a fine-tooth comb. You argued for a people-centered, actionable data. So you've talked about actionable data now, and we've throughout, more recently we've talked about the system, being highly centralized, and you want it to be decentralized. So we've gone on to this concept of people-centered, actionable data. What does that mean in practice?
In practice, we've spoken, at length about the importance of disaggregated data, and we've also indicated that it's important to be very specific in the way the data is collected, because it allows us to, manage resources. And one thing that we need to understand during emergencies is that the figures we are seeing, there are people behind those figures. There are people behind those figures. And when we talk about a people-centered data, we want those figures to actually reflect their realities. We want our paper was pointing out to the government that it's important to reduce the impact of data misconducts during emergencies, because there are so many people that feel their data has been collected and action will be taken that will benefit their health, that will help them get out of a situation. But the data that has been collected does not reflect their reality. Along the way that data was transformed, along the way that data was mismanaged, along the way that data got missing. And they are quietly sitting in their houses and thinking, oh, the government came here and took some information regarding my symptoms, and so I'm hoping that I'll have a feedback, but they never get those feedback. So I think deviating from that is not being people-centered. Emphasizing the importance of keeping the integrity of data, from data collection, from case identification, to transmitting the information to the central level. There should be that integrity, and the government should be able to put systems in place so that the health facilities, the simplest level of the health system, are able to start addressing issues with the information that they have, rather than waiting for all the bureaucracy to happen. Those are some aspects that demonstrate that a system is being sensitive to its people and is becoming more people-centered.
And actually, there's a couple of points you've raised there that I think we could go into. The first bit is about data being a number and not fully telling the people behind that number. So when we talk about, like I talked about earlier, said that over 1,000 people died in Louisiana after Hurricane Katrina. That's over 1,000 families, stories, and I think that as researchers in this field, one of the things is that we've become, well, some of us have become quite desensitized to what the numbers actually represent. I know during COVID, that was a huge problem. If the numbers were going down, people said, oh, great, everything's getting better. yes, but that number still represents something. It
Yeah.
still represents every single one. It still represents a family, a husband, daughter, mother, child, sibling. It's still that's gonna traumatize and hurt that family and that group around them. And I think that as researchers, sometimes we get in this trap that we desensitize to this. And I think one of the reasons why we do it is that if we worry about everything, if we don't desensitize, we harm ourselves, by not being desensitized to it. And I know that during the COVID lockdown, and I think we were in the UK when this, when the first lockdown was happened, remember rightly. But during that first lockdown, one of the broadcasters, and this was only after the first few deaths, flipped it on its head and actually started reading out the names and put up the pictures of those who had died, to highlight what it represented and actually put a picture to the numbers. Now, and it really, and I'll put a link at the bottom of this video, to show that. And as someone who, I was, still doing a PhD at that time, working in this field, but I've been working in the field for quite a few years, and that actually hit me really hard because when we look at numbers, we don't see the story, we don't get the picture, we're not personal to the, what's going on. The second that a picture, the name, the age is read out, you are sensitized to it now, and then you realize what you're doing, what you're seeing, what it represents, and it raises something that I know that we're going to be doing later in the year on another podcast, is looking at the mental health of researchers and the mental health of practitioners in this field. And it's something that I feel that we don't put enough attention, is that, because if we sensitize, we harm our own mental health, but we need to sensitize to understand what the harm has really been doing. So it's a horrible trap that researchers and practitioners get into in this field. And the other point on what you mentioned was governments collecting data and people expecting, governments and other organizations to respond to that data. And it becomes a bigger question. And I don't know if you want to respond to this, where as a society, we have more data than we ever had in history. But the way that we do data collection now is we do it and we move on. And we don't reuse data for other purposes, because there's a lot of data. Now, in my field, I'm next year going to unveil a project that is going to try and end this practice a little bit. But what I see is data is almost expendable. You collect the data for one paper, one research project, or one little scenario, and you leave it. And I don't know if you feel that that is the same in the health sector as well.
Yes, that's the same. I mean, it's you know, I will share this little experience with you. I've been working with displaced women for a couple of years now, and I collected some data on uh, some field data on intimate partner violence, and the data were really interesting data. And I've been thinking on how to, you know, get the best out of this data. And I was talking to a friend of mine. I said, you can uh, obtain clearance and do a publication. And I was like, wow, that's really interesting. I was collecting data to inform my program and to tailor my strategies. But now what you're saying is interesting. So there are a lot of NGOs, a lot of structures, institutions that meet people, collect data, and then utilize that data for purposes that don't necessarily benefit the person from whom the data was collected, or doesn't solve their problems. And it's really something that I think is not always done on purpose. It's not always done on purpose, but with the increasing need, for instance, of funders want data, they want information, they want this, they want that. A lot of fundees, if I can say that, respond to the funders' needs and priorities rather than responding to the needs and priorities of their population, of the people that they are collecting that information from. For instance, you can collect this data on intimate partner violence, and the only organization that wants to fund you says that they will only fund data related to the men's mental health in relationships. And so, you have to close an eye on the problem you identified on the field, which was that perhaps women were battered. There's so much feminicide and all of that. You have to close an eye to that, and because you are interested in the funds they will give you, you start focusing on men's mental health, which is important, but it's not the priority need of that community. It's not the priority need of that community. So those are some of the issues that we face on the field. Data is collected, we have so much information, but what do we do with it? We have selective, we have a very selective way of acting on the information, which is very unfortunate, very selective. You look at databases, there's so much information collected, so much, very intimate. At times you have to talk to someone in such a confidential way, and they're disclosing that information to you because they are thinking of finally going to get the help that I need, but it never reaches them.
And it's so true about the funders bit. I mean, a lot of the time we have to create new data if it's a priority of the funder. We use that data once, and that's it. And it's like, well, that data could be used for a lot of other projects. And it actually frustrates me, and it's something that I know that in the UN, this is going to be something that's going to come up more and more. And it's also going to come up more with researchers in the future, because as budgets are getting cut for research, we're going to need to be more strategically smart on how we do research and what we spend research money on. And I think that reusing data, if it has another alternative purpose, is going to be very important. And yeah, it's just I know that in the UK we're really struggling for finances now, and you have to do research, but I still see this scenario where people say we must collect data. Well, you probably have the data. There's a lot of data out there right now, and I remember during COVID, a lot of the students, we were both at the same institution at the same time. A lot of the students were coming to me, I had students who were coming to me worried about, well, how am I going to collect the data? My argument was that in most cases, that data is probably already being collected and it's out there somewhere. And all you have to do is just take that and analyze it in a different way to it was analyzed the first time. As long as you say that the original data collection is from X, Y, and Z, that's fine. All data collection, all research, and analysis is going to have some degree of critique and some degree of downsides. the original one will have. So I mean, so I guess I'm trying to, I like to drill across more with students today and researchers is that, stop creating so much data and actually start reusing data.
Yeah.
We have been speaking now across multiple episodes for 2.5 hours plus now.
Wow.
So yeah, so there's still a few. I've got three main questions left to get through that I had, and the first one was, what lessons from Cameroon can be applied to other conflict-affected region states? So we know that we are in, post 1990 world. We are probably in the most dangerous periods we've been in. We've got conflicts in the Middle East. We've got conflicts in Sudan. We've got, the M19 rebellions in the DRC. We've had military juntas, in multiple West African states, including Niger, in recent years. What can, what can these countries learn from Cameroon?
You know, um, Cameroon's disaster profile is increasingly becoming it's deteriorating as the years go by. Uh, we are experiencing more more conflicts. Yes, this is a time when there's so much conflict at the individual level, at the national level. It's just a very sad sight. And from my end, I have a particular interest in displacement, in the dynamics of displacement amid all this conflict. And one thing stands out to me is that there isn't a lot of there isn't much research done in the domain of displacement when it comes to conflicts and disasters. Uh, I mean, displacement, looking at it from the perspective of health. And it's very important that fragile states uh, have a hands-on vision of how what displacement does to their health system. My current my current paper is working on understanding the level of access that displaced women have to sexual and reproductive health services. And one thing that pushed me to take up these studies, because working with displaced women, you know, a lot of them engage in prostitution. They engage in prostitution primarily because they do not have a means of subsistence, and just that door, that entry point, leads to so many other things that compounded can be very disastrous for the health system. A few days ago, we had a report of a lady who, a 26-year-old displaced lady who was pregnant, abandoned by the father of her child, and she gave birth. She presented herself at the delegation with this 2 weeks baby. She's hungry. She looks sick. The baby looks sick. She has been sleeping in a motel because that's the only place she could find a bed to lie on. A friend took her there, and the condition for her to sleep there was that she should prostitute herself. And she has been sleeping with men without protection. And with everything that happened, she was referred, and then her baby got taken from her. She doesn't know where her baby is. The only way she can eat or find is to go back and prostitute herself without protection. You're thinking about STDs that will be spread. You're thinking about HIV that can be spread through that. You're thinking about her mental state. Her mental state is so deteriorated that when she meets another individual, what impact will she have on that individual's life? So that's a level of vicious cycle that states are falling into because uh, countries are looking at the most visible problems during conflicts, and those visible problems include, the person who are fighting against, ammunitions, who is being killed, where is the money coming from to fund but they are forgetting that we are creating bigger problems for ourselves. So to answer your question, if what other countries should learn from Cameroon is to begin investing in research regarding displacement and health, because there is a bigger hole awaiting fragile states if they don't figure out a way to integrate displaced people into their health system. The health system will become overwhelmed by the burden that will be brought into the host communities by displaced persons. Thank you.
Yeah, I can, just listening to you, I can just think of, the problems that displaced people are going to have, and the longer term impact on the healthcare system of that country after the conflict. I can just imagine right now. I mean, you mentioned STDs, HIV, in this case. I mean, I don't know if there's any research, that do conflicts increase risks of STDs and HIV? That would be, interesting to find out, is this the case? And if it is, you know, then we got to come back and come to the question, what do we do? How do we stop this? Because as a part of the Sendai framework, we're supposed to be reducing deaths and illnesses from disease, and with more and more conflicts, happening, I can I can just theorize here, but that's not going to be the case. That's actually going to do the reverse, and so I can just see here that we've failed on the Sendai framework in this case.
The standard framework also foresaw a lot of things that are very relevant to the current disaster profile of many countries, and that's very appreciated. We are just kind of very hopeful that governments will understand that they need of paying more attention to these aspects of management. Yeah.
And it moves on to next question about what would a resilient disaster surveillance system actually look like in fragile or conflict affected settings.
To look at a resilient health system, there are a number of pillars that are being scored to be able to say that a system is resilient. And one of those is look at the workforce. The workforce of the system, is the system able to maintain the workforce that they have. You also look at the ability of the system to conduct basic services amid the crisis. You see, during an outbreak, is the system is a health facility in an area where there is a cholera outbreak able to continue receiving out patients, outdoor patients, while simultaneously managing cholera cases. If a health facility is able to do that and their figures are showing that they are having, the same or more number of consultations as they had before, even though they are managing that cholera crisis, is an indication that this facility is resilient. You see, also the capability of the system to be able to pay their staff. If you're able to disburse resources and be able to take care of your staff during the cholera outbreak, because the cholera outbreak will imply that there should be extra mobilization of resources so that you can attend to buying new equipment, transport sample system, responding, providing a quarantine space for cases that are coming in, rehydration solution and all of that. Put that in place needs resources. And if a system is able to put those resources in place and still ensure that their other aspects of the facilities are functioning, that is also a reflection of a system that is resilient. And we go further to look at a system that can take up other activities amid the cholera outbreak. For instance, if a health facility is able to engage maybe in, outdoor sensitization during the cholera outbreak, they're managing cholera outbreaks in their facilities, they're having good consultations and managing other disease cases, and then they add an extra exercise of going out to the communities and sensitizing the staff on what they should do, how they should practice preventative measures. That's a reflection of a system that is resilient, that has received a serious blow, but then has managed to sustain their activities and even go further to initiate other activities.
And my final question: after doing this research, what worries you, the most about how the world handles outbreaks of diseases in conflict zones?
Yes, this at the end of my of writing this paper, I was even more interested in public health emergency management, because I discovered that there is a lot of work that needs to be done in that domain. I I also discovered that there are a lot of little aspects that are overlooked, but that at the individual level we can actually contribute in building resilient this resilient system resilient systems, by understanding our environment, uh, leveraging on our indigenous knowledge. In Cameroon, we have a very rich repertoire of indigenous knowledge. Although our challenge remains in documenting that repertoire adequately, but when you look at what is available, you see that there is so much in terms of disease management, that we use our local plants, we use behavioral ways to manage diseases, and it's very slowly that sort of knowledge is dying off. I'm happy because there are some people that have that as their research focus in the health indigenous knowledge in Africa. And it's so important because at times our health facilities are overwhelmed. Our health facilities are overwhelmed, and you find that a lot of people start relying on indigenous knowledge. I'll share with you what happened during the COVID-19 pandemic in most African countries. Most African countries relied on medicinal plants in order to sustain themselves because there was a paranoia that you couldn't go to the health facilities. Going to the health facilities or seeking medical help was tantamount to, a death sentence. So everybody stayed home, and you had things like ginger, garlic, limes that you do an infusion and drink. And so many people testified, oh, this helped me, my symptoms disappeared because of this, and so on. And you see, right up to today, the prices of those commodities that were used during the COVID-19 pandemic have skyrocketed and have never been the same. Ginger, you could get a bucket of ginger for 2,000. Now ginger is so expensive because they have discovered that they have medicinal traits. They have medicinal traits, and people use it for auto medication, and it helps them. So that was something that my study helped me to come to terms with, that we might also have our own way of helping ourselves if when our health system is overwhelmed.
Mm. And absolutely, and sometimes using more traditional ways is good, but it's also quite bad as well. So during COVID-19, obviously we saw the theory of ivermectin, you know, which is a parasitical treatment course usually reserved for horses in particular, but animals more generally, would kill COVID-19 and help you treat it. To this day, there's no research that actually ever proves that. But social media, online, you know, push that. And then another one, which is a little bit more closer to my heart, is fatty liver. Um, Fatty liver, is a disease that kills increasingly more and more people in the West. Now, one of the ways it is being portrayed as a natural solution to burn it off and increase your metabolism of fat in the liver is turmeric. Now, yes, having some turmeric is good for that. But the problem is if you have too much turmeric, it damages the function of the liver. So it actually does the opposite effect. It actually damages the liver. So it's a bit of a. It's again, it comes back to this fine line we keep mentioning, is that sometimes indigenous knowledge is good. Using products, actual products in particular that have nutritional and health benefits, but they have to be done in a way that is not detrimental to someone's health as well.
Yeah, I agree with you. The one of the major highlights or disadvantage of indigenous uh, medicinal drugs is the posology. How do I take it? How often do I take it? All of that's not documented. When we're small and you had moms, our mothers used to put ash fire, burn wood, ash, and just put on our jaws. And in 2 days, you clear off, you no longer have moms. But what quantity of ash do you put? They don't know your antecedent. The modern medicine is more sophisticated in that they have background, they have this data to be able to know that, okay, this person is allergic to this particular molecule of this medication, so they cannot take it. Modern, traditional medicine often fails to give that sort of details. But then we cannot also ignore some of the good that it has done. So it's just, at times it's just to understand the benefit versus the risk.
Absolutely, and it's it's one of them things where we, as disaster researchers, we modern medicine is great, and it's something that we need to be careful of, because a lot of social media, a lot of media, and it's not, across the world. It's not just one particular country where modern medicine seems to be under attack, and more traditional forms of medicine seem to be taking, precedent, and yes, as you mentioned, there are some, it's going to benefit. It's about how much we take, etc. But a lot of time, some of these traditional medicine are not going to cure a certain illness. I mean, I remember in Belarus, the leader of Belarus, if I remember right, left of my head, said drink vodka to cure COVID-19. Nope, that doesn't work either. And so we just got to be, I think, very careful, because a lot, in quite a few cases, is the treatment is doing more harm than, benefiting the
Yeah,
patient.
yeah.
Kadia, thank you.
Hello.
So thank you very much for this multiple episode podcast. We've been going on for a marathon 3 hours, which is the longest interview the IDRiM podcast has ever done. And thank you to the viewers for sticking with us through these many episodes of the IDRiM podcast. And we hope to see you very soon.